Hello everyone and welcome back to our MRCP Part 2 High Yield Revision Series. I am Dr. Walaaddin and here we go now.
Today's episode is all about ACE inhibitors, a drug class you must know inside out for exams and real-world practice.
Hello everyone and welcome back to our MRCP Part 2 High Yield Revision Series. Today's episode is all about ACE inhibitors, a drug class you must know inside and out for exams and real-world practice. We'll break down how they work, their side effects, and most importantly, how they slot into the NICE hypertension algorithm.
Absolutely. If there's one antihypertensive group you'll see again and again on the ward, in clinics, and in the exam, it's ACE inhibitors. They're first line in younger patients, and they play a huge role in heart failure, diabetic nephropathy, and secondary prevention of ischemic heart disease.
But here's a key exam pearl straight away. ACE inhibitors are less effective as monotherapy in patients of Black African or African Caribbean ethnicity, and that's exactly why ethnicity matters in the NICE guidelines.
Right. So let's rewind and look at the mechanism of action, because once you understand this, everything else makes sense. ACE inhibitors block the angiotensin-converting enzyme, stopping the conversion of angiotensin 1 into angiotensin 2.
And angiotensin 2 is bad news, a potent vasoconstrictor. So when we reduce it, blood vessels relax, systemic vascular resistance falls, and blood pressure drops.
Not only that, lower angiotensin 2 also means less aldosterone, so the kidneys excrete more sodium and water, less volume, lower pressure. Simple and very testable.
There's also a really important renal effect, especially in diabetes. Normally, angiotensin 2 constricts the efferent arteriole in the glomerulus.
Exactly. So when we give an ACE inhibitor, the efferent arteriole dilates. That lowers intraglomerular pressure, reduces protein leakage, and protects the kidneys. That's why ACE inhibitors are first line in diabetic nephropathy.
Quick pharmacology reminder. Most ACE inhibitors are actually prodrugs, activated via phase 1 hepatic metabolism. Easy mark if it comes up.
Now let's talk about side effects, and this is where exams love to trip people up. The classic one?
The dry cough occurs in about 15% of patients, can appear months or even up to a year after starting treatment, and it's due to bradykinin accumulation.
And the one we really worry about? Angioedema. Rare, but potentially life-threatening, and again, it can happen late, not just at initiation.
Don't forget hyperkalemia, especially in patients with renal impairment or those on potassium-sparing medications.
And don't forget first-dose hypotension, particularly in patients already on diuretics. That's a very common exam scenario.
Let's move on to contraindications. ACE inhibitors are a definite no in pregnancy and breastfeeding.
They should also be used very cautiously in renovascular disease, especially bilateral renal artery stenosis, where they can precipitate acute kidney injury.
Patients with aortic stenosis are also at risk of severe hypotension.
And of course, ACE inhibitors are contraindicated in anyone with a history of hereditary or idiopathic angioedema.
A very practical prescribing point. If the baseline potassium is 5.0 millimoles per liter or higher, you should seek specialist advice.
Interactions matter too. Patients on high-dose loop diuretics, for example, more than 80 milligrams of furosemide daily, have a much higher risk of hypotension when you start an ACE inhibitor.
Monitoring is non-negotiable. Always check urea and electrolytes before starting, and repeat them after initiation or any dose increase.
A mild rise is expected, up to a 30% increase in creatinine, and potassium up to 5.5 millimoles per liter is usually acceptable.
But a dramatic rise should ring alarm bells for undiagnosed bilateral renal artery stenosis.
Common ACE inhibitors you should recognize include ramipril, enalapril, and lisinopril.
Now, let's pull this all together with the NICE hypertension pathway.
Step 1. For patients under 55 or those with type 2 diabetes, start with an ACE inhibitor or an ARB.
But for patients 55 or older without diabetes, or those of Black African or African Caribbean ethnicity, step 1 is a calcium channel blocker.
If blood pressure isn't controlled, step 2 is dual therapy, ACE inhibitor plus calcium channel blocker, or ACE inhibitor plus thiazide-like diuretic.
Step 3 is triple therapy, ACE inhibitor, calcium channel blocker, and thiazide-like diuretic.
And step 4, if potassium is below 4.5, add low-dose spironolactone.
If potassium is above 4.5, consider an alpha blocker or beta blocker instead.
And if blood pressure is still uncontrolled despite 4 drugs, that's when you refer for specialist review.
So, to wrap up, ACE inhibitors are central to hypertension management, especially in younger patients and those with diabetes, heart failure, and renal disease.
If you understand their mechanism, side effects, contraindications, and nice placement, you're in a very strong position for MRCP Part 2.
Thanks for listening, and we'll see you in the next high-yield episode.
If you like this series, please hit the like button and subscribe for videos like this. Bye for now.